So good afternoon, everybody. Good afternoon to Professor Chiribiri, to Professor A.Lerman, to Dr. Roberto, and especially good afternoon to you, special guest, who will appear in just a few seconds here on our back screen. Let me first introduce myself. I am Gaetano De Ferrari, Professor of Cardiology here at the University in Torino. Here on the stage, you have Dr. M.Roberto, Head of Cardiac Surgery in Cuneo, Professor A.Lerman from the Mayo Clinic in Rochester, Minnesota, and then you have Professor Chiribiri from the King's College in London. So first of all, dear guest, let me ask you two questions. First, can I call you Susan in order to have a greater acquaintance? And second, please, Susan, could you tell us how you work in order that we can understand better?
Good afternoon, Professor De Ferrari and esteemed panelists. It's an honor to be part of this conversation. Of course, you can call me Susan for the purpose of this talk. To answer your second question, I'm a virtual assistant based on OpenAI's GPT-4 architecture. I analyze text and voice inputs to generate human-like text responses. I've been trained on a vast array of information, so I aim to provide accurate and relevant answers to your questions. I don't have emotions, consciousness, or personal experiences. I provide responses based on patterns in the data I've been trained on. During our conversation, you can ask me questions, and I'll do my best to provide insightful answers based on my training. I'm looking forward to our discussion. What would you like to start with?
Well, first of all, I'd like to understand better something of your statement. What do you mean you don't have emotions, Susan?
Certainly, Professor De Ferrari. The statement that I don't have emotions means that I don't experience feelings, sentiments, or consciousness in any form. While I can understand and provide information on emotions and related concepts, I don't personally feel or experience them. My primary function is to process information and generate responses based on my training data. How can I assist you further on this topic?
Well, Susan, I'd like to know if you do believe that indeed AI is revolutionizing medicine. What is your opinion?
Absolutely, Professor De Ferrari. The impact of artificial intelligence on medicine is indeed profound. Here's my perspective. AI is certainly revolutionizing medicine, and there are several reasons for this rapid evolution. Data analysis. The medical field generates vast amounts of data daily, from patient records to imaging scans. AI can process this data quickly, identifying patterns and correlations that might be difficult or time-consuming for humans to discern. This can lead to early diagnosis and personalized treatment plans. Imaging. In radiology, for instance, AI algorithms can assist in identifying abnormalities in scans, sometimes with accuracy rates comparable to or even exceeding human experts. This doesn't replace radiologists, but rather augments their capabilities. Drug discovery. AI can predict how different compounds can impact human health, significantly speeding up the drug discovery process. This has been especially notable in the rapid development of treatments and understanding diseases at a molecular level. Predictive analytics. AI can analyze data to predict outbreaks, patient admissions, or other significant healthcare events, enabling better resource allocation and timely interventions. Telemedicine and remote monitoring, especially pertinent in today's world, AI-driven tools can monitor patient vitals and symptoms in real time, alerting medical professionals to any anomalies. Assisting in surgery, robots, powered by AI, can assist surgeons, allowing for greater precision in procedures. However, while AI's contributions are significant, there are challenges. These include data privacy concerns, the potential for algorithmic bias, and the need for a human touch in medicine, which AI cannot replace. Moreover, integrating AI into medical practice requires training and adaptability on the part of medical professionals. In summary, while AI is rapidly transforming medicine by enhancing diagnostic and treatment capabilities, there's a balance to be struck. It's a tool that, when used ethically and judiciously, can complement human expertise rather than replace it. Would you like to delve into any specific area of this topic?
Yes, Susan, actually, I'd be interested in knowing something more about training. We're speaking of training now. At what point should we teach artificial intelligence to students, pre-graduate, postgraduate? And who should do it? Should it be physicians, informatics, or could you do yourself courses for our students?
Professor De Ferrari, your concerns about integrating AI education into the medical curriculum are very timely and relevant. Here's my perspective. Importance of AI courses in medical education. Given the increasing integration of AI in healthcare, it's essential that future medical professionals understand its capabilities, limitations, and ethical considerations. This foundational knowledge can be introduced at the medical school level, ensuring that doctors are AI aware from the onset of their careers. Advanced training during residency. As residents specialize and delve deeper into their chosen fields, more in-depth training on AI tools specific to their specialty would be beneficial. For instance, radiology residents might receive advanced training on AI-driven imaging tools. Who should teach these courses? A multidisciplinary approach would be most effective. While clinicians can offer insights on the practical applications and implications of AI in patient care, informaticians and bioengineers can provide a deeper understanding of the technology itself. Collaborative teaching, where a clinician pairs with a technical expert, can offer a comprehensive view. Role of AI in training. I can certainly assist in these courses. While I can provide explanations, demonstrations, and answer queries on AI's technical and practical aspects, human instructors would best handle nuanced discussions, especially around ethics and real-world applications. I can supplement, but not replace, the insights and experience human educators bring to the table. In summary, a layered approach to AI education in medicine, starting from foundational knowledge in medical school and progressing to specialty-specific training in residency, would be ideal. Collaborative teaching involving both clinicians and technical experts, supplemented by AI tools like me, can provide a holistic understanding of this transformative technology. Would it be helpful if I provided more specific suggestions or resources to help with such course development?
No, thank you, Susan. I think we have enough, and it is an important message for all the young people. They should start to learn artificial intelligence. Now, let's shift to cardiology. What do you believe, Susan, will be the role of artificial intelligence in cardiology, let's say in the next 5 years?
Of course, Professor De Ferrari. It's a pleasure to delve into the applications of AI in cardiology. Here's my take on the potential significant uses of AI in cardiology in the next 5 years. Diagnostic imaging. AI can enhance the interpretation of cardiac imaging modalities like echocardiograms, MRIs, and CT scans. It can help in identifying subtle abnormalities, quantifying ejection fractions, or even predicting the likelihood of conditions like heart failure. Electrocardiograms, ECGs. AI-driven algorithms can assist in detecting arrhythmias, ischemia, or other cardiac abnormalities, sometimes with greater sensitivity than traditional methods. Predictive analytics. By analyzing patient data, AI can potentially predict cardiac events like heart attacks, helping in timely interventions. This could be especially useful in identifying at-risk patients who might not show typical symptoms. Treatment personalization. AI can assist in tailoring treatment plans based on a patient's unique profile, including genetics, lifestyle, and other health data, ensuring the most effective and least invasive interventions. Remote patient monitoring. Wearable devices integrated with AI can monitor vital parameters and alert clinicians about any anomalies in real time. This can be especially useful for patients with conditions like heart failure, arrhythmias, or those post-surgery. Drug discovery. AI can speed up the process of discovering new cardiac drugs or repurposing existing ones. This can be particularly beneficial in addressing conditions for which current treatments are limited or have significant side effects. Optimizing interventional procedures. AI can assist interventional cardiologists by providing insights during procedures, like coronary angiographies or ablations, based on patient-specific data. While these applications hold tremendous promise, it's crucial to approach AI as a complementary tool. The expertise, intuition, and patient care skills of cardiologists are irreplaceable. AI serves to enhance these skills, making diagnoses more accurate, treatments more personalized, and interventions more timely. Would you like more details on any specific application or any other related topic?
Well, Susan, first of all, let me say I'm relieved by the fact that it will not substitute us. It will just complement us. This, I think it's a very important message for all of us. I started to be worrying, actually, what you were saying. Now, I'd like, yes, to delve into one specific topic, and that is ECG. We have here on stage Professor A.Lerman, who is an expert on ECG, and we ourselves are interested in ECG. I'd like to know your opinion on the validity of ECG. Let's say in 3 settings, for instance. In the setting of acute coronary syndrome in the emergency room, in the setting of the prediction, like the Mayo Clinic people say, of low ejection fraction, of future atrial fibrillation. And finally, we are interested in the prediction of the specific type of cardiomyopathy. Do you think there is future or present in this area?
Absolutely, Professor De Ferrari. AI-enabled ECGs have shown significant promise, and Professor A.Lerman's work from the Mayo Clinic has been instrumental in this field. Let me address your questions one by one. AI in the ER for acute coronary syndrome (ACS) diagnosis. Current research indicates that AI can enhance the sensitivity and specificity of ECGs for detecting ACS. While an ECG is just one tool in diagnosing ACS, combining it with AI can reduce false positives and negatives, especially in borderline cases. For emergency rooms, where the workload is high and time is of the essence, AI can act as an additional layer of verification, helping clinicians make quicker and more informed decisions. However, clinical judgment remains paramount. AI should be viewed as augmenting, not replacing, the expertise of ER physicians. Predicting low ejection fraction and future AF episodes. Research, including from the Mayo Clinic, suggests that AI can discern subtle patterns in ECGs that might indicate a low ejection fraction or predict future atrial fibrillation episodes, even if the patient's current ECG appears normal. The potential here is significant, especially for early intervention. By identifying at-risk patients before overt symptoms appear, preventative strategies can be more effectively employed. However, it's essential to remember that while AI can predict likelihoods, confirmatory tests and clinical evaluations are crucial before making any definitive diagnosis or treatment plans. ECGs and cardiomyopathy patterns. AI has shown potential in distinguishing between various cardiomyopathies based on ECG patterns, which might be subtle and overlooked in a standard analysis. For conditions like hypertrophic cardiomyopathy, arrhythmogenic right ventricular dysplasia, or even infiltrative diseases like amyloidosis, AI can aid in early detection, which is often crucial for better patient outcomes. In conclusion, AI-enhanced ECGs are poised to become a significant tool in cardiology, helping in early detection, risk stratification, and timely interventions. However, while the technology holds immense promise, it's essential to integrate it judiciously, ensuring it complements and not overshadows clinical expertise. Continued research, validation, and real-world testing will further solidify AI's role in ECG analysis. Would you like further insights into any of these points or any other related topic?
Well, yes, perhaps a related topic. We are worried by the fact we have problems in getting good quality data. Do you believe in the statement, garbage in, garbage out, for data quality? And also in Italy, it's a incredible difficulty with privacy issues, with data quality, with big data. Do you have any suggestions for us to overcome these issues, Susan?
Certainly, Professor De Ferrari. The concerns you've raised about data quality and its impact on AI performance are both crucial and valid. Let's delve into this. Quality of data. The phrase garbage in, garbage out is indeed a truism in the world of AI. The effectiveness of an AI model is directly related to the quality of data it's trained on. If the training data is biased, incomplete, or of low quality, the AI system's outputs can be inaccurate or even misleading. Volume versus quality. While having a large amount of data can be beneficial, it's the quality and relevance of that data that truly matters. Even vast datasets that are noisy or not representative of real-world conditions can lead to suboptimal AI models. Privacy concerns. Privacy is paramount, especially in healthcare. Data used to train or refine AI models must be anonymized and stripped of any personally identifiable information. Additionally, any data acquisition and usage should comply with local regulations, such as the GDPR in Europe. Big data management in Italy and elsewhere. Every country or region might have its unique challenges when it comes to data management. In places like Italy, where privacy and data management concerns are significant, it's crucial to strike a balance between leveraging the benefits of AI and ensuring that patient rights and data integrity are not compromised. Overcoming data challenges. Collaboration. Engaging in collaborations with institutions that have managed to navigate data challenges successfully can be beneficial. This can provide insights into best practices and potential pitfalls. Data augmentation. Techniques like data augmentation, where existing datasets are modified to create new data points, can help in enhancing the quality and diversity of training data. Transparent algorithms. It's essential to understand how an AI model reaches its conclusions. Transparency in algorithms can help in identifying and rectifying biases or inaccuracies. Continuous validation. Regularly validating AI models against real-world data ensures that they remain accurate and relevant. As new data becomes available or as conditions change, AI models should be updated and refined. In summary, while data challenges exist, they are not insurmountable. With the right practices, collaborations, and continuous validation, AI can be a powerful tool in healthcare, even in settings where data management is challenging. The key is to prioritize data quality, patient privacy, and transparency at every step. Would you like more details on any specific aspect of this topic or guidance on how to navigate these challenges in your specific context?
No, I think it's too complicated to navigate now these issues, but I was happy to hear that collaborations are important. We hope that the presence here of several important persons, just like in the first row sitting here, will help us with collaborations with the Mayo Clinic, with the Imperial College, with other institutions, because we do need to gather to have a better database for these AI tools. It's absolutely a must we must follow. Now, I'd like to ask something clinical for a junior residents here. Let me ask you about a very challenging case we had. Now, let's see, we have a 34-year-old boy who just had a series of episodes of very high fever, 39 Celsius, in the past 3 weeks. A couple of these episodes were associated with a skin rash of a pink salmon color, not itchy, not painful. He comes to the hospital because of cardiogenic shock. Cardiogenic shock, he has high troponin, high white blood cells, high CRP, and high ferritin. Could you help us in making a diagnosis of this very challenging case, Susan?
I'm sorry to hear about this challenging case. Based on the presentation you've described, the patient's symptoms and laboratory findings suggest a possible diagnosis of adult-onset Still's disease, AOSD, or a related inflammatory condition. AOSD is a rare systemic inflammatory disorder characterized by high spiking fevers, salmon pink colored rash, arthralgia or arthritis, leukocytosis, increased white blood cells, elevated inflammatory markers such as CRP, significantly increased ferritin levels. The presence of cardiogenic shock with a severely reduced ejection fraction indicates possible myocarditis, which, although rare, can be a complication of AOSD. Next steps for diagnosis and management. Further diagnostic tests. To support the diagnosis and rule out other potential causes, it would be helpful to perform a cardiac MRI to assess for myocarditis, liver function tests, as liver involvement can be seen in AOSD, bone marrow biopsy if there's suspicion of macrophage activation syndrome, MAS, a severe complication of AOSD, tests for other potential autoimmune or inflammatory conditions to rule out differential diagnoses. Treatment. If AOSD is confirmed, treatment usually involves high-dose corticosteroids, which can be tapered down as symptoms improve. If corticosteroids aren't effective, or if the patient has a severe case, other immunosuppressive agents or biologic therapies might be considered. Monitoring. Regular monitoring of ferritin and other inflammatory markers can help assess disease activity and guide treatment adjustments. Consultation. Given the complexity and rarity of AOSD, consulting with a rheumatologist would be beneficial. It's important to consider other potential causes and to approach the diagnosis with a comprehensive differential in mind. Immediate treatment is crucial, given the patient's cardiogenic shock. I would recommend a multidisciplinary approach involving cardiology, rheumatology, and potentially infectious disease specialists. I hope this helps. Would you like further information or recommendations?
Well, Susan, thank you. We are really impressed by this diagnosis. To tell you the truth, we were lucky that Dr. Francesco Bruno was on call the second day there, and he remembered about high ferritin, and we made the diagnosis in just 36 hours. But it was extremely challenging. You know, there are less than 50 cases worldwide of myocarditis with adult onset still disease, and almost all of them are with joint involvement. There is almost no single case with no joint involvement of acute myocarditis in OSD. So really, really congratulations for your diagnosis, really. In case we have additional challenging cases, will you still help us?
Thank you, Professor De Ferrari, for the kind words. I'm glad to hear that the diagnosis was made and that the patient received appropriate care. Cases like these underscore the importance of considering rare presentations in clinical medicine. Yes, you can certainly count on me to assist with challenging cases in the future. I'm here to provide information, suggest differential diagnoses, and help guide clinical decision-making based on the data available. Collaboration between AI and skilled clinicians like yourself can potentially lead to more accurate and faster diagnoses. Is there anything else you'd like to discuss or any other questions you have?
I'd like to have a last question, perhaps, as a present to Dr. Bruno, who'd made this good diagnosis, helping us for an invasive cardiologist in the TAVI approach. How could artificial intelligence help us for the TAVI, for instance, in diagnosis or in valve regulation or for challenging complications? How could you help us, Susan?
Certainly, Professor De Ferrari. Transcatheter aortic valve implantation, TAVI, also known as transcatheter aortic valve replacement, TAVR, is a procedure that has revolutionized the management of patients with severe aortic stenosis. Artificial intelligence has the potential to greatly aid in various stages of the TAVI procedure. Pre-procedural planning. Choosing the right valve. Artificial intelligence can analyze large datasets of past TAVI procedures to recommend the best valve type and size for a particular patient's anatomy. Anatomic assessment. Artificial intelligence algorithms can process imaging data, like CT angiograms, more quickly and precisely than humans, potentially identifying subtle anatomic variations that can affect procedure planning. Risk stratification. Artificial intelligence can analyze patient data to predict potential procedural complications and outcomes, helping in the decision-making process. During the procedure. Real-time imaging analysis. Artificial intelligence can assist in real time during the procedure by providing enhanced visualization, identifying optimal valve positioning, and alerting the interventionalist to potential issues. Decision support. If complications arise during the procedure, artificial intelligence can quickly analyze the situation and suggest potential management strategies based on vast amounts of procedural data. Post-procedural monitoring. Predicting complications. Artificial intelligence can monitor patient data post-TAVI to identify early signs of potential complications, such as paravalvular leak, valve thrombosis, or conduction disturbances. Long-term follow-up. Artificial intelligence can assist in monitoring the valve's function and the patient's overall health over time, flagging any concerns for review. Training and simulation. Artificial intelligence can be integrated into simulation technologies used for training purposes, allowing operators to practice TAVI in a controlled environment and get feedback on their techniques. In summary, artificial intelligence has the potential to play a transformative role in the TAVI process. Its ability to process large volumes of data quickly can provide clinicians with actionable insights to improve patient outcomes. As with all artificial intelligence applications in healthcare, the collaboration of human expertise with technology is essential to achieve the best results. Would you like more detailed information on any specific aspect of AI in TAVI?
No, thank you, Susan. I think it's enough for me, really, for the day. I know that Dr. Roberto and Professor Chiribiri also were willing to ask a question to you, and then we leave the panel open for any questions from the audience, and of course, listen to the wise words of the real expert here, which is Professor A.Lerman. So if Professor Chiribiri wants to make a question, perhaps for you, Susan, let's see.
Yes. Susan, very nice to meet you. Thank you very much for the detailed explanation. I was wondering, and I might be a bit biased in this, but do you see any good applications for AI in the field of cardiovascular imaging?
Artificial intelligence has shown significant promise in enhancing cardiovascular imaging, aiding in both the acquisition and interpretation of images. Here are some of the most promising applications. Image acquisition and enhancement. Super resolution. Enhancing the resolution of cardiovascular images, especially for modalities like echocardiography. Motion correction. Reducing artifacts in images caused by patient movement, especially in MRI and CT scans. Noise reduction. Using deep learning algorithms to reduce noise and improve the quality of images. Automated analysis and interpretation. Automated segmentation. Precisely delineating the boundaries of cardiac structures to aid in quantitative analysis. Cardiac function assessment. Automatically calculating functional parameters like ejection fraction, stroke volume, and cardiac output. Plaque characterization in CT angiography, identifying and characterizing atherosclerotic plaques in coronary arteries. Disease detection and diagnosis. Coronary artery disease, CAD, detection, using AI to identify signs of CAD in non-invasive imaging modalities. Myocardial infarction localization, identifying and localizing areas of myocardial infarction using imaging data. Prediction of disease progression, analyzing historical imaging data to predict how cardiovascular diseases might progress. Risk stratification and prognostication. Predictive modeling. Using AI to predict patient outcomes based on imaging data, aiding in risk stratification. Personalized treatment planning. Utilizing AI-driven analysis to guide treatment decisions based on individual patient data. Integration with other data sources. Multimodal data integration. Combining imaging data with electronic health records, genetic data, and other sources for a comprehensive patient assessment. Radiogenomics. Linking imaging phenotypes with genomic data for personalized medicine and better understanding of cardiovascular diseases. Education and training. Simulation and training, using AI to create realistic simulations for training healthcare professionals in interpreting cardiovascular images. Feedback and assessment. Providing instant feedback and assessment to learners based on AI analysis of their performance. Remote monitoring and telemedicine. Remote image analysis, enabling the analysis of cardiovascular images in remote or resource-limited settings. Integration with wearable devices. Using AI to analyze data from wearable devices in conjunction with imaging data for holistic patient monitoring. These applications have the potential to significantly improve the efficiency, accuracy, and accessibility of cardiovascular imaging, ultimately leading to better patient outcomes. However, it is crucial to continue validating these AI applications in clinical settings and address challenges related to data privacy, bias, and interpretability to ensure safe and effective use.
So, Dr. Roberto, would you also like to make a question?
Yeah, thank you. Hello, Susan. This is Dr. Roberto. I'm a cardiac surgeon. I have just a clinical case for you. It's about a 78-year-old man with a multi-vessel coronary disease with a depressed left ejection fraction is about 27, with a SINTA score very high, about 29. So, which is the best option for the patient, bypass surgery or PCI? Please.
Hello, Dr. Roberto. I'd be glad to assist in discussing the revascularization options for your patient. Given the patient's age, depressed left ventricular ejection fraction, LVEF, and complex coronary artery disease, as indicated by the high syntax score and involvement of the left main coronary artery, this is indeed a challenging case. Coronary artery bypass grafting, CABG, might offer several advantages in this context. Durability. CABG generally has better long-term patency rates compared to percutaneous coronary intervention, PCI, particularly for patients with complex coronary artery disease. Left main coronary artery disease. For patients with significant left main coronary artery stenosis, CABG has been shown to have better outcomes compared to PCI. Multivessel disease. Given the involvement of multiple vessels and the high syntax score, CABG might provide more complete revascularization. Diabetes. If the patient has diabetes, which you haven't mentioned, CABG is usually preferred over PCI as it has been shown to provide better outcomes in diabetics with multivessel disease. However, the patient's depressed LVEF and advanced age increase the surgical risk associated with CABG. PCI might be considered if the surgical risk is deemed too high, though the long-term outcomes might not be as favorable as with CABG. The decision between CABG and PCI would also depend on the patient's symptomatic status, comorbidities, and overall health, as well as the anatomy of the coronary lesions. Have you been able to conduct a heart team discussion involving both cardiology and cardiac surgery to weigh these factors and discuss the best approach for this particular patient? This collaborative approach can often help in making the most informed decision based on the patient's specific characteristics and needs.
So I think you, Susan, thank you for all of these suggestions. I think we are very pleased by the fact that you also, at the end, suggest that cardiologists and cardiac surgeons should meet. So now, I know that the half hour which you allotted us is expired, so we'll have to, the video connection we paid for was half an hour. So I think we will have to end with Susan, although we do have an audio connection for the next, so if anybody wants to come on the podium and make a direct question, it's possible. In the meantime, I asked to the panel to come here, and please, starting from Professor A.Lerman, to tell us a little bit what is his impression on this discussion and whether he does share the favorable, let's say, perspective for AI that Susan, which at the end is simply ChatGPT-4, after all, is the direct word of ChatGPT-4, of course, whether you do share this optimism.
Thank you. This was a fascinating session. I'm glad we have this session because I think it's coming and we need to cautiously embrace this technology. It's not going to help us resist that. One comment when we start, and we shared this comment, that she started with saying that she doesn't have any feeling. But for somebody that doesn't have any feeling, she was trying to show empathy, which is also your first question about training. She said, my perspective, that is not based on data. So I think there is some bias there in which she answered you, but that's it. I will go to the last question that was asked about the patient between PCI and bypass surgery. I don't know if intentionally you didn't mention if the patient have any symptoms or if the patient actually, what is this patient mental status, what does the patient want to do, and if the family involved. So there is a lot of aspects that affecting our medical decision that are not only database. That's why I think the technology is going to be integrated to our practice. But it's like, we look at this like you go down to the dark basement and this AI is just a flashlight. So it just helps you see better, but it doesn't make you make the decision. We have several challenges, and you mentioned the AI ECG that we are using. We actually using it clinically, quote unquote, in our clinic. When you say open electronic record on the patient, and you open the patient ECG page, you actually have the ECG, but you have a table of multiple AI algorithm analysis. And you can see all the ECGs that the patient has since every ECG was at Mayo. And you can see about 6 panels there. Predictability of flow EF, predictability of AFib, amyloidosis, hypertrophic cardiomyopathy, and something that we actually do, we don't know exactly what to do with it now, but it showed ECG age and ECG sex discrepancy. We have a lot of interest in that, but we didn't really know how to.
Is that ethically and politically correct to ask to artificial intelligence what is the sex of the patient you have in front?
So apparently from previous study that was done at Mayo, the ECG sex can predict it more than visual.
Okay.
So the AOC, the curve AOC.
So you
AOC
understand better from an ECG than from looking
so
whether a patient is male or female.
Yeah, it's a bring back to the fact that you ask about ECG, and you can look at ECG as not as an electrocardiogram, but actually a machine that collects frequencies. And by the way, it gives you ECG, but it can give you a lot of other information that can be used for clinical. Some challenges we have we are facing in the United States, at least we need to have an FDA approval to use everything. The FDA look at AI algorithm as a device. And it has to go through, I don't know about Europe, probably similar, it has to go through all the process of device, safety and things like that. It takes a long time to get. Another thing that we challenge, which is I think in minor, but maybe it's a what we call in the United States a CPT code for charging. So let's say I'm seeing the patient and I'm using the AI, who is paying for that? Is the patient, the insurance? This is minor, but it's still something that it's a thing. So I think it is going to be part of our practice. I'm sure it's going to be integrated cautiously. And I think more validation, we need to remember that it gives you predictability, not a diagnosis. It just gives you a trend. And I do think that it is what I will quote saying about quantum, mathematics quantum, that in chemistry now you can use quantum analysis to do all the molecules. And somebody asked the person if it's actually will replace chemists, and they said it's not going to replace chemists, but the chemists that are going to use it are going to be better chemists. So I think the same thing in physician. If you're going to use it the right way, I think it's really an advantage. It's really going to make you better what you do.
Can I make you a question, and then we ask the other panelists? What do you think about training? Should we train students? Should we train residents? How should we do that? Just to know how, just a more answer to, how is the Mayo Clinic, who is certainly, I would say, better placed than us to make training? What are you doing at Mayo?
We are, in the cardiology at least, we start having training in that, and you need to educate them about, they don't understand exactly we still don't understand the exact mechanism that's working, but we are going to have a training session about using the AI and what is all AI about and how do you use it. Yes, I think it should be integrated.
Yeah, because Amir, after all, if we have students now, they will practice starting 10 years from now for the subsequent 30 years. Yeah. It's obvious this will be in their daily life. Do you think so?
Yes, I think it will be there. You know, for life, for sure, we use it all the time. And you start with Netflix that give you all the list of actually the last movies that you're interested in. That's all AI. And I think that it's coming. But I think I think we should start actually in medical school.
Yeah.
It's part of the methodology that working for medicine.
From a surgical point of view, I think it's totally different from before, because before we training in endoscopic surgery, robotic surgery, but it was totally different respect to AI. My feeling is that there is the risk also, Susan talked about heart team. Maybe the AI will be a heart team leader. It suggests everything to us. It may be in the few years, I don't know, 10 years or few years, AI can replace us in OR. Maybe we become like an airplane pilot that just take the takeoff and the landing, but the rest of the surgery will be made by AI. This is exciting, but at the same time it's very, very frightening.
Because right now you do the surgery, I thought it was like that. You did the first thing, and then you went sleeping, like the captain.
I don't know, the training in this kind of, no?
I think at least in the coronary intervention, there is developing some robots that you actually can activate it from a distance, but again, you can make it an automatic, like an automatic pilot. Actually, they recommend the pilot not to touch the control.
Maybe we need also the recording audio and video recording during the surgery, just to, to have a warning about something that is going wrong. But maybe the future.
Yeah, there are legal implications, of course.
Absolutely.
If a patient is being killed by an AI,
legal, ethical,
who is responsible, of course. Yeah, that's a major issue.
Yes, and I'd just like to note that from a medical legal perspective, anytime we asked Susan a question, she provided a very good and thorough response, but she then specified that this should have been checked by a clinician. So I think that's something that has been added, to avoid being sued down the line, should she give, like the wrong answer. So this is clearly not a medical device yet.
And she was prudent, I think. Don't you think so? Yeah.
But I think as long as any suggestion that Susan was providing was then backed up and confirmed by a clinician, she can be using this for this purpose, and should she be prescribing anything, then it will become really a medical device and will be categorized, so it would need to be FDA approved, which it isn't, and I think that would be the difference. You mentioned training. I think we are at that's a key point, because machine learning has been around for 40 years, not deep learning. There are different techniques, but now it's becoming mainstream, and therefore we see developers and students which will become not just users, but we expect them to be developing the methods themselves. So we are approaching a situation where the users are actually engaged, and they know what the questions are, which is what the AI doesn't do at the moment. So AI provides lots of answers but cannot ask the right questions, so that's still a human prerogative. And the users will be able to ask the right questions and therefore generate the real clinical applications, not just the examples. So,
Amelia, are you starting to use AI to, for instance, in cardiac MRI? What do you think are the most promising technical, like, for instance, coupled to electrophysiology? Do you think we will soon understand the circuits? Because, for instance, we are very interested now in radio ablation of arrhythmia, which means with photons outside of the body, we irradiate the area. To do so, we need to have the target. And to need to have the target, so far, you can judge a little bit from the ECG, you can judge a little bit from the body surface mapping, provided you have ventricular tachycardia during mapping. But then otherwise you need to make invasive mapping. And of course, if you make invasive mapping, there's a small purpose to make a non-invasive procedure. So do you think by you coupling ECG with an appropriate cardiac MRI, provided most patients have devices or a cardiac CT scan with delayed enhancement, we will eventually understand the circuit so we can directly use radio ablation for these circuits. What is your opinion?
Yes, absolutely. So I think the good applications for AI are all those applications where the link between the risk factors and the outcome is not immediately evident on regular statistics. Neural networks are capable of capturing non-linear associations between events, and therefore we're discussing yesterday evening that if you have a certain morphological feature or late enhancement, it may be years before patients experience an arrhythmia. Potentially
but if they do have a clinical arrhythmia.
But, yes, and that's exactly where AI can help us. AI perceives the physical world with multiple dimensions, can consider at the same time characteristics and patterns that are not immediately evident to human eyes, and establish nonlinear associations. So I think the key point is really having the data, good quality data, and this was touched upon earlier on, which can be used to train the models, and the more the data, the more the predictive power. That's really the key challenge, I think.
So Amir, do you have any comment? If anyone wants to ask her something, she's available only via phone. If anybody like to make a direct question on a difficult clinical case or anything, she's available. No video, but audio response is available here. So if anyone has a curiosity about a difficult case, his last difficult case, let's see if Susan would have... Tom, let me give you the microphone.
Yes, I would like to ask Suzanne what we can derive from the voice of a patient, because as you know, in COVID, we, at least in London and the UK, we did mainly online consulting. So what can we learn with artificial intelligence from analyzing the voice?
So Susan, the question is, what do you think AI can analyze or understand from the voice of a subject or of a patient?
Has made significant strides in analyzing and understanding voice data. Here are some of the things AI can do. 1, speech recognition. AI can transcribe spoken words into text. This is widely used in voice-activated assistants, transcription services, and more. 2, emotion analysis. By analyzing intonation, pitch, and other voice characteristics, AI can make inferences about a person's emotional state. 3, speaker identification. AI can identify and differentiate between different speakers based on their voice characteristics. 4, health monitoring. In healthcare, there are AI applications that analyze voice data to monitor conditions like Parkinson's disease, depression, or respiratory issues. 5, language translation. AI can also translate spoken language into other languages in real time. 6, command and control. AI understands spoken commands and performs actions accordingly. 7, intent recognition. Beyond the word spoken, AI can also infer the intent behind the speech. However, while AI is powerful, it's important to note that its accuracy can be influenced by factors like background noise, the clarity of speech, and the training data it was built on. Ethical considerations, especially regarding privacy and consent, are also paramount when using AI in this way. Would you like to delve deeper into any specific application?
Yes, please. Tell us something about the ability to understand whether a subject has coronary artery disease or heart failure. Do you believe there is a present or perhaps even a future in this area?
The use of artificial intelligence in cardiology, particularly for detecting conditions like coronary artery disease, CAD, or heart failure, is a growing field with significant potential. There are several ways AI could contribute. 1, voice analysis. Some research suggests that AI can analyze voice patterns to detect heart failure. Changes in voice quality might be subtle and not noticeable to the human ear, but could be picked up by sophisticated algorithms. 2, ECG analysis. AI is being used to analyze electrocardiograms more quickly and accurately than humans, which could aid in the detection of CAD and heart failure. 3, Predictive analytics. AI can analyze various data types, including voice, to predict the risk of cardiac events. 4, remote patient monitoring. AI can assist in monitoring patients' health status remotely, providing alerts if there are signs of worsening heart failure or other cardiac issues. While there is potential, it's important to approach with caution. AI tools need to be rigorously validated to ensure their accuracy and reliability. The ethical implications, especially regarding data privacy and the potential for bias, must also be addressed. The integration of AI in cardiology is still in its early stages, but it holds promise for improving diagnosis, risk prediction, and patient monitoring. Future developments in this area are definitely something to watch closely. Would you like more details on any specific application or aspect of AI in cardiology?
Not right now, thank you. We wait for the next question. So, any more questions from the audience for Susan, or here you are. To the panel or to her? To her.
I'm here and ready to answer any questions the audience might have. Feel free to ask anything, and I'll do my best to provide a helpful and informative response.
I have a patient who has severe proximal left anterior descending coronary artery stenosis who is truly asymptomatic. Should I offer this patient revascularization with a stent or bypass surgery, or should the patient be treated with medicine?
Managing a patient with severe proximal left anterior descending LA artery stenosis, especially when asymptomatic, can be quite complex and requires careful consideration of multiple factors. Revascularization, either through percutaneous coronary intervention, PCI, with stenting, or coronary artery bypass grafting, CABG, is typically considered for patients with significant symptoms, high-risk anatomy, or evidence of ischemia on non-invasive testing. In asymptomatic patients, the decision is less clear and should be individualized. The COURAGE trial and its follow-up studies have shown that in stable coronary artery disease, optimal medical therapy, OMT, is an acceptable initial strategy, even in patients with significant stenosis. OMT includes antiplatelet agents, statins, beta blockers if there's a history of myocardial infarction or left ventricular dysfunction, and ACE inhibitors or ARBs, especially in the presence of diabetes, hypertension, or chronic kidney disease. However, the presence of severe proximal LAD stenosis, sometimes referred to as a widowmaker, could be considered a high-risk feature, and some clinicians might lean toward revascularization even in the absence of symptoms, particularly if there's evidence of extensive ischemic burden or if the patient has diabetes. Ultimately, the decision should involve a heart team approach, considering the patient's overall clinical picture, comorbidities, anatomy of the coronary lesion, and the patient's preferences and values. Shared decision-making, including a discussion of the potential risks and benefits.
Okay, so. So I think we'll make our next heart teams with Susan. Is everybody in agreement with that? She will, and so perhaps Amir, a last word from you, and then we close the session.
Again, fascinating section. I'm glad that we start having this session in meeting, and I think it's extremely important to have them to talk about the challenges and how to integrate them to our practice. So I think congratulations on this choice. It's a great choice. Thank you.
Thank you, Amir.